thanks a lot. Good afternoon, and sorry to keep you from the coffee break, but we had some timing challenges. I did my PhD here at Karolinska in the Department of Public Health Sciences. I finished in 2011, and I've come to this class several times now at Annette's invitation, and the reason I like this class a lot is because I did this class. I took this seminar, the Career Services Seminar, and in my last year, it was about a year before I defended my PhD, and thinking I can no longer be a student, what in the world am I going to do after? And it helped me a lot, actually, to sort of do some clarification of what I was interested in. And then there was a point in the course, I don't know if you still have it in the seminar, but we had to do like a cover letter to a job and got feedback on that. It was a smaller group. But, and so I was looking for a job that I could write sort of a fake cover letter to, because I wasn't yet looking for a job. And that's how I found the job that I first got at ECDC. So I feel very grateful, and I always say yes whenever I'm invited to the seminar. But, and so I wanted just to share with you a little bit about what ECDC, the European Center for Disease Prevention and Control, does, and then also what it's like to work there, and what I got in my PhD training, which has been useful there, and also some things that I didn't get, perhaps. And then if you have any questions about what it's like to work there, or life after Karolinska, I'm happy to answer them. And I will have, because I need to run at 5 minutes to 3, I have my email address, and ECDC is very close. It's just 5 minutes walking, and so it's very easy. I'm happy to have a visitor there or to meet you sometime if you have additional questions. So you may not have seen ECDC. It's just behind Karolinska. It's at Tomtebodaskolan. And I hadn't really been by there or really noticed that ECDC existed there, because I was working within global health. And so ECDC works on it's a European Union agency, and it focuses on communicable disease. So although I was working on communicable disease in my PhD, I was focused on HIV, but it was more global health, and my studies were in Vietnam. So I didn't have much contact with ECDC during my Karolinska days. But it has been there since 2005, and it works in terms of networking on communicable disease issues across the 28 countries that are European Union member states, plus the European Economic Area. And it's been here in Stockholm since its inception. The mission of ECDC is to identify, assess, and communicate current and emerging threats to human health. So we don't deal so much with animal health. We coordinate with other agencies that are working in that area. And we coordinate also with agencies working on food safety, on drugs issues, for example. And we are only about 300 people working there, including administrative staff. And so it's really kind of a skeleton staff, because we cover over 42 different infectious diseases. But we work a lot with the public health agencies, for example, Folkhälsomyndigheten here in Sweden, and all of the other agencies in the other countries, who often have much more staff, because the countries are responsible for the response to the infectious disease problem or the outbreak, whereas we work to network across countries, across laboratories, and to share and communicate information, and to give a picture of how things are in Europe. But we're not responsible for actually implementing measures to stop the outbreak. That is done by countries themselves. And so there's a lot about surveillance and early warning systems, sharing information across borders, and then also pooling health knowledge. So if a smaller country or a country less familiar with that particular infection or virus has a sudden outbreak or a sudden challenge, they can ask the network of experts or another laboratory to confirm or to help or assist. And ECDC started in response to SARS, over 10 years ago, realizing that there were these significant cross-border health threats, and there really wasn't a mechanism in our region to deal with them, and so that was one of the biggest impetuses for the beginning. We use a lot of scientific evidence to inform health policy. So in contrast to what one does when working within research, where you're generating primary evidence through the studies or the experiments that you're performing, we are using that evidence to then try to collate it for decision-making, for health policy. And it's been very interesting for me, moving from the side of sort of generating individual studies for science to then trying to look across studies, and maybe through systematic reviews, to understand then how policy should be implemented. It's interesting to see how the policymaking process happens, or what things that policymakers lean on and ask for, which sometimes aren't very scientific. And so it's an interesting intersection between those two worlds, and I enjoy that. So we do a lot of collating data, and I'll show you some examples of that, so surveillance data from across Europe. We also, I mentioned systematic reviews, so that's pretty much the only way that we look at evidence. So we would never look at usually a single study, but we'd look at the body of evidence to then say, okay, what does all of the evidence in this area say in terms of whether this vaccination strategy should be implemented or whether this particular pathogen is a threat to this particular population. Sometimes there isn't enough evidence, and then we'll pull together expert panels when the scientific literature is not good enough, or when maybe we need to look at the literature in relation to a new problem, in a similar problem. We'd ask an expert panel to help us consider that. And then sometimes we use those systematic reviews and expert panels to issue guidance. So it's up to countries themselves to decide which policies they will implement. We definitely cannot make them implement a certain policy, but we are there to say the evidence is there to show that this is the best strategy. Or your neighbors are doing this, maybe you want to consider it. We do have training, so both on the laboratory side and the epidemiological side, and a department that works with that, and then we have disease networks, and so one of our functions is bringing them together every year or two to exchange information and help each other. We work in sort of 7 disease program areas. The first is not really a disease, but antimicrobial resistance and healthcare-associated infections, and then kind of more traditional areas of emerging and vector-borne disease, food and waterborne disease. The program I work in is HIV, sexually transmitted and bloodborne viruses, influenza, TB, and vaccine-preventable disease. And this is our organogram, which is really maybe not so interesting to see in detail, but just to show you that we kind of have this matrix-like functioning. So we have the disease programs here, and then I sit in surveillance, so most of my time is spent on surveillance. I work a lot with my colleagues in scientific assessment, and we work for specific disease areas. And we can be reallocated if there should be a big outbreak. For example, when Zika virus was taking a lot of media attention mostly, but it wasn't such a big problem in Europe. Some of our time in our program was allocated toward looking at sexual transmission of Zika virus, even though that's not something we routinely work on. One of the disease surveillance areas is that we have one database, all of the countries, for example, Swedish Public Health Authority has communicable disease laws in Sweden, where disease information is reported to Folkhälsomyndigheten. That is then reported on to ECDC. So according to European law, there's 42 diseases under surveillance where countries then report to ECDC, and that is in a common database, a common data format, with no personal identifying information there, but sometimes information that is helpful to understand disease transmission and factors related to it, age factors, for example. And then this can be used, for example, by researchers such as yourselves. You can do a data access request if you'd like to do a secondary analysis of measles trends over time by country. And it's also used by other agencies. So we're kind of a clearinghouse for that information. And this is a big improvement from the way it used to happen before ECDC. There were 30 different places where data was stored in different formats across Europe. So there was really nowhere to get a picture of all the diseases in one place. And so, for example, for HIV, we'll then produce maps like this so you can look at the burden of new infections across countries and compare that to see where you might see larger burdens of infection. And then we also look at this, of course, over time and by risk group. In addition to disease surveillance, we look at, I've given examples from the HIV area, but there's of course many different areas, but this is looking at global targets. And so countries have signed up to a global target for HIV to get 90% of the people who are diagnosed with HIV on treatment, that's antiretroviral treatment. And so the countries that do have data, the target is 90%, and this is what countries most recently reported, those who did have data. And so these green countries are sort of at or above the target. Those in blue are around the EU average of 83%, and then there are many countries in yellow who are still quite far from the target that they've aspired to meet by 2020. So this is sort of a benchmarking so that countries can see how they're performing next to each other and maybe give each other some positive peer pressure. And then we also do policy monitoring. So this relates, this is treatment guidelines. And so this relates to recently in 2015, WHO and also the European AIDS Clinical Society put out new guidelines for treatment, saying that people should be treated as soon as they're diagnosed with HIV and not wait until their CD4 count falls to a very low level. And so previously we saw that only 4 countries were implementing immediate test and treat, which was then found to be the much more effective way of treating and also preventative on population scale. So when we asked countries in 2014, when are you initiating treatment, this is what we got, at different CD4 thresholds. And then once the guidelines were implemented, we've seen a very big change in our region toward countries implementing the test and treat. And we should, therefore, in the coming years, see the HIV incidence go down. We'll see, and we'll continue to monitor that. So just a very simple policy monitoring also. Wider outputs and our epidemiological updates, so on things like Zika or issues that are sort of forthcoming and of interest. Right now, weekly influenza is of interest to a lot of countries. We put out epi updates routinely. There's also risk assessments. My colleagues are working on one today about hepatitis A virus cases and new strains, which was of interest to some of the countries. And then these are published in the public forum to give information to countries and to epidemiologists in terms of how to react. And then I mentioned surveillance reports. We'd also do technical reports, which maybe would be like a systematic review or literature review, guidance documents. And then we do have some communication toolkits, for example, on vaccine provision, getting people to comply with influenza vaccination was an example. And then some colleagues of mine who work in the disease threats area just launched an app a few days ago, now in February. So you can get several of these things by downloading this free app, and then you could get information on what are the new sort of epidemiological updates that ECDC is publishing. So that could be of interest. And there's a lot more, which I don't really have time to go into, but we have a map making tool, which is free to download and use if you need to make maps of Europe, and you can do that at national level or else subnational level if that's of interest. We have a surveillance atlas of infectious disease, so the surveillance data that we collate can be compared there. If you want to look at 2 different countries over time, you can explore that. And there are other things. There's a geoportal, the E3 geoportal, where you look at environmental factors along with infectious disease factors. So please have a look if you think that any of this is in your area. I wanted to move to, this is the first job that I got at ECDC, which I mentioned at the beginning. And so I thought I'd just show you some of the criteria that were in the job description, actually, of my first job there. Just, so this is when I was like 1 year from finishing the PhD. This is what was in the job description. And this is why I actually sent in the application, because I didn't need a PhD to get the job. And so I thought, well, I don't need to wait until I'm finished. I'll apply now. So one needed 2 years of experience, 1 in the job area. And I had worked in the field of HIV before. An academic degree. I'm a nurse by profession, so I had that already, and I'd studied public health in my master's. And then to be familiar with the general area of HIV/AIDS and hepatitis B and C. I worked a bit on that as well at the beginning, particularly looking at populations at risk, because in HIV and hepatitis, there are certain populations at higher risk, and so trying to understand and have a sense of that was important. Project management, experience working on national or EU level, which I actually didn't really have a strong experience in that. I'd worked mostly globally in Vietnam, in Zambia, and Uganda, not really at the Swedish national level previously. Good command of English, interpersonal skills, ability to work well under pressure, and then being able to translate a scientific message to a public health message for maybe a more popular audience also. So those were the selection criteria, and they seemed like manageable, so I did apply. And then these were some things that I did in that job at the beginning. So it was kind of in a 1 year period. These were sort of the 5 big projects that I worked on, and I thought it could be of interest to then describe that. So how did I use what I did in my PhD in this? So one of the projects I worked on was a project we had outsourced. So because we have only 300 staff, we can't do all of this work internally at ECDC. So we tender out a lot of projects. So this particular one, it was a guidance on prevention of HIV and other sexually transmitted infections in gay men. And it was a project that we tendered out, so we said we'd like a systematic review done of what are the best ways to prevent HIV and STI. And so I was the project manager for that, so giving input and almost acting, sometimes it felt like a supervisory role, like what my PhD supervisor did, I had to do for them. So I say, yes, you're on the right track, no, we'd like feedback, please redirect, we need these things included. And then they delivered that systematic review. We held an expert panel, and then the writing of the guidance was done collaboratively. So I had to do some of it together with this academic group. Another project was also outsourced project management, and that was a systematic review. number 2. And then the third updated risk assessment was in response to an outbreak of HIV among injecting drug users in several countries in the EU. So we therefore did a rapid query of countries trying to understand the situation and if there was indeed a problem that was European-wide or if it was just focused in these 2 countries, which we found that it was only focused in those 2 countries. And then in response to that, we did technical support for one of the countries, which was Greece, at their request. So we went there about 4 times and looked at their national services and gave input and feedback. And then finally was the policy monitoring. I showed you where you looked the treatment. For example, we do policy monitoring every 2 years in our area of HIV. So it was to look at and do project management on that project. So kind of a wide, diverse bit of work. Some of it was internal, where I got to do data analysis, and other things were trying to coordinate and manage the projects. Beyond what I've described at ECDC, these are sort of other work areas that some of my colleagues work in. So my section is surveillance, and there's a lot of people who are focused on the surveillance of a particular area, like Legionnaire's disease or measles, mumps, rubella. And so all of the disease areas that I showed you, we have experts who are working on surveillance. We also have people that are more on the database side, so working on that big European surveillance system database. Program managers who are responsible, their work is more administrative, but they have a scientific background, so to do the planning of the work that we carry out and monitoring to make sure that happens on time. There's a group that's working within threat detection. I haven't spoken much about that, but every day at 11:30, there's a meeting of people who are routine. Every day, there's a person assigned, several people assigned, to screen the news, there's a closed platform which countries can use to share information. We think we're seeing this. Is anyone else seeing this kind of like vomiting or these types of pathogens? And so they can ask in a closed platform, and then it is discussed every day at 11:30. It's the daily roundtable. And then they come up with a report from that every day saying, these things seem to be happening. Does anyone else notice them? Yes, no. And this is then sometimes a platform where they can say, you know what, more work needs to be done on this issue. So we're going to do more analysis and more, like maybe pull together an expert panel on issue X or Y. And then there's the country support section does a lot of work trying to see, are countries prepared, for example, for new pandemics? Do they have systems in place? Do they have laboratory preparedness plans in place? So there's a lot of work in country collaboration and preparedness there. Health economics is an area that 2 of my colleagues work in, burden of disease as well. Biostatistics, of course, is an area that we have several people working in, and then evidence-based medicine. So we have one expert actually, and then a second one who partially works on this, who really just give advice on what is the best way to use the systematic review process to support a guidance. Microbiology, we have a section that works on that, and then monitoring and evaluation. So some of my personal reflections are, I do enjoy, ECDC is a very diverse environment, and I had come from global health into this European agency, so I thought it would be a bit boring because it was only focused on Europe. And I've found that not actually to be true. It's really interesting, and there are people from all of the different EU countries, and then many others who have a background, before they became a Swedish citizen, they maybe came from Kenya or came from Russia. So it's really, really diverse, and people speak many languages. That's also a challenge because we have really different backgrounds in terms of, just like planning processes and communication. So that can be challenging. And then also not only culturally diverse, but it's also professionally diverse. So there are people who come, like I do, from academia, but then there are others who come from the private sector or who come from really the bureaucratic government sector. And we have really different ways of working, and also, I would say, different standards for like quality, and so sometimes that's interesting to negotiate. It's very outcome driven. We work on an annual work plan, and I thought that was interesting and kind of nice after the PhD studies where I would work for months, sort of, often it felt like alone. Now it's much more teamwork, but also much more, you have to deliver a project by the end of the year, by a certain maybe event that it's built around. And so regardless sort of whether you feel you're done, it needs to be done. And so that is different, but I feel that more is able to be achieved as well compared to what I felt in my PhD study. Very multidisciplinary, I mentioned that. Also more hierarchical than a typical Swedish working environment. Everything that I write has to be approved by 4 other people before it can be published, sort of like cleared by the chief scientist. So when I write, it's in the name of ECDC, and so our chief scientist needs to make sure that that message, what is being recommended, is also approved. And I haven't found that to be a problem, but it is interesting and very different than the academic freedom that you have of kind of recommending whatever you'd like to from your research results. And then we're employed by the EU, which means that we work outside of the Swedish system. So for any of you who are Swedish, that is a difference. So we have like private health insurance, for example, and aren't in Försäkringskassan. And then finally, we work on really assessing threats to human health. And I mentioned this at the beginning, we're not responsible to implement the programs. And so if you're someone who really likes hands-on work and wants to work in the field and actually implement things, I'm not sure this would be for you, because we stop at the level of assessment and perhaps giving options for advice. But it's others in the countries and really at the subnational level who are going to be implementing the programs to respond. So these are things that I did in the PhD to different extents that I think would be helpful in work at ECDC. I'd say first and foremost is scientific writing, both being able to write for a scientific audience, but even more importantly, for a non-scientific audience. So people who are policymakers, who don't have a lot of time, who don't want to go into a lot of detail, so they really want to get like the elevator version of the story. That is important. I use epidemiology and biostatistics because I work more on the surveillance side. I don't routinely use as much of health promotion and communication as some of my colleagues in that section do. And then health policy and systems analysis, so understanding how the different health systems might affect the recommendations that we're giving. Infectious disease specific knowledge and health systems understanding, I mentioned. And then microbiology and virology are really important, particularly for some of the disease areas like influenza, for example. And then finally, health economics is used a lot. We do have specialists in that we can rely on. And then I would say something I didn't do any of in my PhD studies, which then I found we use a lot at ECDC, is this issue of systematic review. I never took a class on systematic review here, and then suddenly I got there and that was all that we were using and doing, and I think that would have been helpful and something that I would have benefited from having more of in the PhD training. These are some other possibilities that do exist at ECDC, and I think both applications are in January, so now it would only be for next year if you were interested. But there are these, the European fellowship programs, so the EPIET fellowship program, and then also one called UFEM, which is more focused, EPIET is more focused on epidemiology, UFEM is more for laboratory, but they're both related to working in public health, so working in a network of public health laboratories for UFEM. And you either have to have a background in sort of a medical field or a PhD to apply for these projects or for the fellowships. And they're quite competitive, but really, really good training programs. So you're a part of a network of epidemiologists and microbiologists from across the European Union, and you get special training, which is sort of, it's seen as like the public health leaders of tomorrow. And then there are traineeships as well, which are, you can come to ECDC and work for 3 to 9 months on a specific topic. And those are also aimed at EU nationals. And usually it's every January that one applies for those. So this is my contact information. And like I said, we're really nearby. So I'm happy to talk to any of you on another occasion if that would be interesting or useful, if you have follow-up questions. So sorry to rush through and then soon rush out of here. But
you have time for like one
yeah, I have time for a couple questions.
Yeah, okay, so actually thank you a lot for this nice presentation. So in the case now actually of this ECDC fellow traineeships, I mean, for people who just finished PhD, would you actually recommend them to go for the fellowship or for this some months traineeship? I mean, are they the same or?
The fellowship is about 2 years, and the traineeship is shorter, so depending on your timing, yeah. And then I don't see why you couldn't try both. I mean, there's nothing would limit you. So I think it's, yeah, that is a possibility. And something I didn't mention, but it could maybe be of interest, is that you also, regardless of like nationality or background, we do take visiting scientists. So if something that you're doing has a public health angle or specific microbiology and infectious disease angle, and you're here anyway in Stockholm, maybe you'd want to be a visiting scientist, which would basically mean that you could sit there and maybe interact a bit more in your specific area. And we've had those. Usually visiting scientists would tend to come from outside of Sweden, but why not have someone visiting from Karolinska for a few months? And perhaps that could be of interest if it fits with what your research area is. Yeah. Good, okay.
All right.
Sorry to keep you from the coffee break.
No, thank you so much.
Thanks.